So good afternoon, everyone. I'll let the folks continue to trickle in, but I'm very happy to welcome you to our first in-person session as a portion of this categorical course focused on comprehensive insights into transplant imaging. And we're really excited. This is a new categorical course bringing together the expertise of imagers, surgeons, as well as ethicists, and we are just very excited to bring this topic and share our knowledge and expertise with all of you. The session this afternoon will be focused mainly on heart transplant. We'll talk about congestive heart failure or heart failure evaluation prior to transplant, mechanical support devices that may be a bridge or even a destination therapy. Then we have a surgeon's perspective on heart transplantation. And then finally, we'll finish up with a discussion of some of the ways that we as imagers can help in the pre-transplant evaluation of our patients. Yes? The speaker on this side of the room is not on for our IT folks. Can you hear me in the back, please? I think he is not able to hear me. I'll walk back there once we get started with our first speaker. So this speaker's not coming on. Not working. Okay, we'll handle that. No problem. Thank you, Travis. So as we're addressing the issue with the speaker, in the interest of time, I'll go ahead and introduce our first speaker, who's Dr. Matthew Cham from University of Washington in Seattle, and he'll be speaking on pre-heart transplant imaging.
Thank you. Good afternoon, everyone. It's a pleasure to be here today in sunny San Diego. I'd like to thank Dr. Kim Kalianos and the program committee for the opportunity to be here. No relevant disclosures. The purpose of this talk are to describe the classification of heart failure, to identify the indications and contraindications for heart transplantation, and to discuss the imaging tests for heart transplantation planning. Congestive heart failure is the cardiac pump's inability to carry out its circulatory role. Just like American politics, it may be due to left or right dysfunction, sometimes both. It may be acute or chronic, numerous possible etiologies. It can lead to fatigue, shortness of breath, and life-threatening complications. And it may respond to medical or surgical treatments, although ultimately a few will require heart transplantation. CHF severity is classified by the New York Heart Association criteria, which focuses on functional capacity and symptom severity. Classes 1 to 3 refer to patients who have no symptoms at rest, with Class 1 having no limitation on physical activity, Class 2 and 3 having slight and marked limitations respectively, and Class 4 having significant limitations and symptoms at rest. CHF severity can be further classified according to American College of Cardiology and American Heart Association criteria, which focuses on disease progression and physiology to guide treatment. The ACC and previously described New York Heart Association criteria are not mutually exclusive, but are often used simultaneously. Stage A refers to patients with risk factors but no symptoms. Stage B refers to presence of heart disease without symptoms. Stage C refers to patients with CHF symptoms. And Stage G refers to patients with CHF symptoms that interfere with daily life or result in greater than one hospitalization per year. Let's move on to the imaging findings of CHF. In the earliest stages of CHF, the only radiological finding may be an enlarged heart. As we can see on this frontal chest radiograph, we can see that the lungs are clear, no pleural effusions. As CHF progresses, we begin to see manifestations of pulmonary edema due to increased hydrostatic pressure. Interstitial edema is characterized by peribronchial cuffing, interlobular septal thickening, known as curly B lines on chest radiography, and increased lung markings. On this frontal chest radiograph, we can appreciate the curly B lines and increased lung markings throughout both lungs. CT also demonstrates the same interlobular septal thickening and diffuse ground glass opacification, which represent alveolar edema. Alveolar edema is the more advanced presentation of CHF, characterized by all of the previously described features, plus perihilar airspace disease and pleural effusions. On this chest radiograph, we can see alveolar edema with the typical perihilar distribution. And if you concentrate really hard, you might even see a batwing pattern of edema in some cases. On CT, we can appreciate the peribronchial cuffing, the interlobular septal thickening, airspace disease, and pleural effusion. Other findings in patients with chronic CHF include pericardial effusions, mediastinal lymphadenopathy, and ascites. For the 0.4% of patients who do not respond to traditional CHF therapies, heart transplant may be the only treatment. Approximately 4,000 heart transplants per year occur in the United States. The one-year post-transplant survival rate is quite high at around 90%. The frequency of heart transplantation has steadily increased from about 2,000 in 1991 to approximately 4,000 heart transplants that occur each year today. You can also appreciate the size of the transplant wait list represented by the orange line, which is unfortunately 2 to 3 times greater than the number of transplants represented by the blue line. The absolute indications for heart transplantation include cardiogenic shock requiring continuous circulatory support, persistent New York Heart Association Class 4 refractory to medical and surgical therapies, non-ischemic cardiomyopathies with New York Heart Association Class 3 or 4, severe angina due to coronary disease not amenable to therapies, congenital heart disease with New York Heart Association Class 4 not amenable to therapies, and intractable life-threatening arrhythmias not amenable to therapies. You'll notice that the vast majority of these indications are based on patient symptoms rather than imaging findings. Furthermore, the few indications that I've highlighted in green, which are reliant on imaging, still need to be accompanied by specific patient symptoms. This makes our job in radiology much simpler, as none of the indications solely rely on our imaging findings. There are several specific diseases that are more likely to lead to heart transplantation. 58% of transplants occur in patients with non-ischemic cardiomyopathy, and most of these are patients with dilated cardiomyopathy. In this cardiac MRI, we can see a patient with a severely dilated left ventricle measuring 15 centimeters in diameter, normal being somewhere between 5.5 to 5.8 centimeter. Another disease that can lead to heart transplantation is restrictive cardiomyopathy, which comprises 4% of cardiac transplants. This is a case of a patient with cardiac amyloidosis demonstrating diffuse late gadolinium enhancement throughout the myocardium. Another disease leading to heart transplantation is hypertrophic cardiomyopathy, which comprises about 3% of cases. This is a patient, again on cardiac MRI, demonstrating asymmetric septal hypertrophy, with thickness of the septum being at least 50% greater than the other cardiac segments. Another category that frequently results in heart transplantation is end-stage ischemic cardiomyopathy, which comprises around 32%. Here's an example of a patient with a severely enlarged heart, dilated left ventricle due to 3-vessel coronary artery disease. This patient has multi-vessel transmural myocardial infarcts, resulting in an ejection fraction of 22%. Another category for heart transplantation is congenital heart disease, and about 3% can lead to that. This is a patient with detransposition of great arteries, status post-mustard repair, now presenting with New York Heart Association Class 3 symptoms. You can see a pulmonic conduit right there and a barely visible baffle conduit because of previous baffle stenosis. Finally, some patients with myocarditis also need heart transplantation, and these comprise about 1% of cases. This is a patient on cardiac MRI demonstrating mid-wall late gadolinium enhancement due to viral myocarditis, subsequently being considered for heart transplantation. The absolute indications for heart transplantation include absolute contraindications to heart transplantation include systemic illness with life expectancy less than 2 years despite heart transplant, irreversible pulmonary hypertension, which varies by institution, severe extracardiac organ dysfunction, severe symptomatic cerebrovascular disease, active substance abuse or misuse, and a history of chronic medical noncompliance. There are also relative contraindications to cardiac transplantation, and they include age greater than 70 years, which varies by institution, or body mass index greater than 35. extensive diabetes with severe organ damage, irreversible renal failure, neoplastic or infectious histories, which can vary by institution, acute pulmonary embolism within the past 8 weeks, tobacco use or substance misuse within 6 months, significant risk factors for medical noncompliance, and finally, conditions that limit tolerance for immunosuppression. There are several imaging techniques that are employed for heart transplant planning. Echocardiography is a mandatory imaging test prior to heart transplantation. Transthoracic echo, or TTE, is used to evaluate cardiac function, wall motion, chamber sizes, and valve function. Transesophageal echocardiography can be used to evaluate for intracardiac thrombi or to clarify inconclusive TTE findings. Cardiac MRI is a situational exam. Many transplant patients already have a cardiac MRI long before transplantation is even considered, whereas some transplant candidates may never need a cardiac MRI. MRI is often used to confirm echocardiography findings, including cardiac structure and function. Late gadolinium enhancement sequences are used to diagnose cardiomyopathy and to quantify the burden of myocardial scar or infiltration. As many of these patients with heart failure may have an implanted device, such as an implantable cardioverter defibrillator, it's important to consider the employment of wideband late gadolinium enhancement sequences to better image these patients. That being said, even the wideband LGE sequence can sometimes produce inconclusive results, such as this case, where certain defibrillators or ICD models can create very large susceptibility artifacts, as you can see on this image. In these cases, nuclear medicine can become highly beneficial. Both cardiac SPECT and PET can be performed to evaluate myocardial perfusion, and they are especially helpful when MRI images are degraded by implanted devices. Chest radiography, and particularly chest CT, are required in most cases during heart transplant evaluation. Chest CT is used to identify incidental contraindications to transplant, such as the identification of new cancers that were not previously diagnosed. In this particular patient who underwent chest CT, we found a lytic lesion in the spine as well as a paraspinal mass. These are metastases from an unknown primary that was later determined to be renal carcinoma. So the patient's eligibility for heart transplantation will really depend on the prognosis of this pathology. During chest CT, it's also important to report the severity of ascending aortic calcification, which may affect the surgical approach, and to report the distances between the sternum and the cardiovascular anatomy in patients who have had prior sternotomy and may have adhesions at these anatomic locations. In this particular patient who had a chest CT, we can see a severely and diffusely calcified aorta, which is important to report in our CT scans, as it will affect the surgeon's creativity to perform the anastomosis during cardiac transplantation. Furthermore, in patients with prior median sternotomy, it's important to note the distances between the sternum and the cardiovascular structures, as there is a possibility of adhesions at this location from prior surgery. Abdominal imaging is also typically required in the form of a right upper quadrant ultrasound for anatomic screening. In addition, colonoscopy for colon cancer screening is also typically performed. Abdominal CT is not routinely obtained, but may be beneficial. There is emerging data that routine abdominal CT may detect new incidental cancers in 6% of heart transplant candidates, resulting in either transplant ineligibility or requiring cancer treatment prior to heart transplant and subsequent immunosuppression. This is data that was just published last year. Peripheral vascular imaging is also situational. Carotid Doppler may be performed in patients greater than 40 years of age to screen for their stroke risk. Bilateral low extremity Dopplers can also be used to screen for peripheral vascular disease in symptomatic patients. Coronary catheterization is typically required for heart transplant planning. This is done to evaluate the atherosclerotic burden and for obstructive coronary artery disease. This is typically required for donors that are greater than 40 years of age, as it establishes a baseline in case of future cardiac allograft vasculopathy. Coronary CTA is typically not utilized due to inconclusive results in patients with severe coronary calcification. although it has possible utility in younger donors to screen for coronary disease that are related to substance abuse. It also has a potential use for ex vivo allograft imaging, but at the potential risk of transport or surgical delays. HET-CT is another situational exam, typically performed to exclude significant cerebrovascular disease in patients with neurological symptoms. This is a patient who developed confusion while on the heart transplant list and was found to have an acute subdural hematoma with midline shift. So the prognosis after treatment of this pathology will dictate the eligibility for staying on the heart transplant list. Up until now, we've discussed primarily recipient imaging. Donors also require a thorough clinical workup. Ideal donors are below the age of 45, although there is no strict age limit. Donors must not have any obstructive coronary disease, no severe valve disease, no significant myocardial scar, and no chronic systemic disease such as HIV, hepatitis B or C, diabetes, or hypertension. Size matching the heart between the donor and the recipient is essential for optimizing hemodynamic adaptation. When transplanting a smaller heart, the donor's sex and body weight play an important role, whereas when transplanting a larger heart, the donor's sex and height become relevant factors. More recently, investigators have begun to use total cardiac volume from CT data to optimize size matching, but there's currently no universal standard for this. In summary, CHF is a major public health burden that can lead to heart transplantation. A combination of clinical and imaging findings comprise the indications for heart transplantation. Cardiac imaging is a powerful tool that can aid in improving outcomes. And with that, I'd like to thank you for your attention.
Thank you so much, Dr. Cham, and thank you for fixing our audio to our team in the back.